So, we have here a 35-year-old woman recently integrated Asia, presented to the ED with acute onset dyspnea. She has no cough, chest pain, or fever. She has a history of rheumatic heart disease as a teenager. On exam, she has an irregular pulse of 97, blood pressure of 125/75, temp of 90.8. The first heart sound is loud with a mid-diastolic rumble, best heard at the apex. Crackles are heard at both lung bases. ECG shows an irregular heartbeat and an absent P wave. Which of the following is the most likely cause of this patient's abnormal heart rhythm?
C for cat.
Left ventricular dilatation. Any other takers? So, left dilatation. So, yes, she has mitral regurg because she has a history of rheumatic heart disease, and mitral stenosis and mitral regurg. The mitral valve is the one that's most commonly to be affected by rheumatic heart disease. But I guess this is from the Step 2 Q Bank in UWorld. It says that
to have an arrhythmia.
To have AFib, one of the most likely causes of AFib is from having the left atria dilate because the pulmonary veins are very sensitive to the dilation. So once the left atria dilates, it'll kind of dilate the pulmonary veins as well, and that's what can trigger AFib. So anyone, like Riaz said, with someone that has a mitral regurg, which causes the left atria to dilate, it can lead them into an AFib because of that. So that's the explanation on that one. Okay. Oh, and again, if I think this one's mine too, but if we get to someone else's question, you guys can take the lead and recite the question. So anyways, a 21-year-old man experiences syncope while shoveling snow in his driveway. He regains consciousness within a minute and then rushes to the hospital. He has recently been experiencing shortness of breath and chest pain that is associated with exercise. He denies any health problems, but states that he has an uncle that died of heart problems at the age of 29. His temp is 99.1, BP 126/81, respiration 14, and pulse is 76. Physical exam shows a well-built man in no apparent distress. Lungs are clear to auscultation. A crescendo-decrescendo murmur is heard along the left sternal border with no carotid radiation. Chest X-ray is normal. What is the most likely cause for this patient's syncope? Crescendo, decrescendo typically goes clear with stenosis, but
carotid radiation is the only other thing that those.
Very good. Right. So you got a crescendo, decrescendo with no carotid radiation. So
that can't be aortic stenosis.
Correct, sir. But we've got a 21-year-old with syncope.
Oh, he has like a hypertrophy syndrome.
Yeah, what do we call that?
For being so young.
Hypertrophic cardiomyopathy.
Yeah, hypertrophic cardiomyopathy.
Right. HOCM, hypertrophic obstructive cardiomyopathy. So, which of these?
B.
Interventricular septal hypertrophy. So again, like we were talking last week about the different murmurs, HOCM, is that you have your little the outlet for the aorta in the left ventricle, and it is being obstructed by this. The interventricular septa is obstructing it, so you're not going to be able to get blood flow out that much. So I think Yash was the one that was talking about certain cardiac maneuvers that will improve or worsen murmurs, and HOCM is one that is it better to have more blood in the heart for HOCM or less blood in the heart to improve the murmur, to make the murmur louder? Do we want more blood in there or less blood in there?
Less blood, right?
Less blood, yes, will make the murmur louder, meaning it's worsening. So you want more blood in there.
More blood, so you increase your preload.
Exactly. You want to increase preload, decrease the afterload, because it will push the IV septum over to the side, to the right, I guess, and allow blood to flow out. So, one of the treatment therapies is to not be dehydrated and increase preload. So yeah, squatting and whatever the hell else, raising your legs. Those are
hand grip.
Hand grip increases afterload, not increases preload. All right,
so this one's mine.
Go for it, buddy.
55-year-old woman comes to the physician because of cold intolerance and weight gain over the past 7 months. Her temperature is 98.9, pulse is 55, and blood pressure is 104/62, and respirations are 13. Physical exam shows a dry, cool skin. Lab studies show TSH of 5.2, free T4 of 4, and T3 of 185. Which of the following is the most likely diagnosis? And if you guys need lab values, TSH normal levels is 0.5 to 5. And then E4 is 5 to 12, and then T3 should be 150 to 190.
Well, she seems hypothyroid, so Grace is Hashimoto. No, not Hashimoto.
So you're right as far as hypothyroid, sorry. So Graves is hyperthyroid, so that's correct. So you're wrong. That's wrong answer.
Graves is not right.
What would pituitary adenoma? What lab values would you see with that?
Pituitary. So you've got TSH, which is running a bit high.
Correct.
T4 is
your
low.
T4 should also be high.
Yeah.
Pituitary adenoma.
So your TSH and T4 would be high in a pituitary adenoma?
Yeah. So, anybody have a guess as far as what's the answer?
Hashimoto's?
Yep, that's the correct answer. So the next one, I'll give you the explanation. So there's Hashimoto's has the elevated TSH and then low free T4, and that's consistent with primary hypothyroidism. Now the T3 levels seem normal because obviously you're converting T4 to T3, so that levels may somewhat seem normal, but your T4 is low and TSH is high, so that's kind of gives you the giveaway. Graves is incorrect because it present as hyperthyroid, so usually low TSH and then raised T3 and T4. Pituitary adenoma would have both high TSH and T4, and then subclinical hypothyroidism, which I kind of didn't know until I saw this question, or at least didn't figure out the lab values, but it would be elevated TSH but normal T4, and patients would likely not experience any symptoms. So, and thyroid hormone resistance is just not the right answer. So, because there would be raised TSH and T4. So, any questions with this one?
So subclinical hypothyroidism would be asymptomatic, and you probably only see it on lab values.
Yeah, and I mean, you would see elevated TSH, but your T4 will also be normal. So,
Gotcha. All right.
So, yeah, that's neat. All right, so this one's also mine. A 68-year-old woman comes to the physician because of abdominal bloating, belching, flatulence, and foul-smelling fatty diarrhea for the past 4 days following her camping trip to India. She's had mild nausea but no vomiting, and there is no presence of blood in her stool. Her vital signs are within normal limits. A stool sample was sent for evaluation, but results are pending. Which of the following is the most likely gold standard treatment for this suspected disorder? Albendazole, ciprofloxacin, metronidazole, none needed, or oral hydration therapy.
All right, so she probably had palak paneer. So,
or some sort of fruit. So I think the biggest key is
she was already on.
So she hasn't started any therapy.
Yeah, so it's not C. diff. She's just got
So
in general, kind of poopy gross stuff.
Yeah. So fatty diarrhea, but no blood. That's one big key. So what would you suspect?
She has Giardia.
Giardia
So
would
C
be
metro.
suspected.
Yeah.
And you don't want to start a bigger antibiotic in this patient in case that you're wrong with, and you're waiting for your lab evaluations, because the risk of C. diff are so high in patients who are going to take antibiotics. So that's why you start with metro. I guess that's what the answer. So if you hit the next slide, it says likely develop infectious disease because of proper food hygiene isn't followed, or they drank contaminated water. So in general, antibiotics are not recommended for mild watery diarrhea due to increased likelihood of C. diff infection leading to resistance, but they are indicated in some causes of diarrhea when it's due to either C. diff, Shigella, E. coli, Vibrio, or Protozoa. So this patient's symptoms suggest of acute Giardia, and these symptoms are self-limited but not treated. If not treated, chronic infections can lead to malabsorption. So first line is metro.
Okay.
And then the next slide has the other answers as to why they are wrong. Because albendazole is used to treat roundworms. Cipro is used to treat acute diarrhea in adults. It can be used to reduce length of symptoms, severity, and other bugs. Well, you don't need none is because while in most adults with mild diarrhea, there's no therapy that's needed, but with a patient that suggests giardiasis, metro is the most appropriate treatment. So,
right on. And you give metro because you want to also try and avoid creating C. diff.
Correct.
Yeah. Right on. All right. Whose is this? Whose question is this? I mean. All right. Well, a 25-year-old man who recently returned from Honduras presents to the ED with bloody diarrhea and a right upper quadrant pain. Lab studies show WBC 1400, albumin 2.8, hemoglobin 11.1, hematocrit 33.4, platelet 200 grand. Results of a stool guaiac test are positive. A CT is performed and shown. Here's the CT. So we got some kind of nodule over here. What is the mechanism of the underlying pathology in this patient? Appendicitis, seeding via the portal tract, colonic infection with ascension via the portal tract, gallbladder infection with ascension via the biliary tree, pelvic inflammatory disease and seeding via the peritoneum, or sepsis and seeding via the vasculature. Interesting.
This is my question. The Honduras part threw me off.
Okay.
White blood cell counts are elevated.
Yeah, white blood cells are elevated. Albumin is a bit elevated.
Platelets are normal, or is that supposed to be 20,100?
Platelets are normal.
Yeah, it's supposed to be 201,000.
Okay.
So yeah, and yeah, so think about like differentials for bloody diarrhea.
So this is another poop thing,
Yes. And they're bleeding. So, well, okay, obviously the stool is positive.
Bloody diarrhea and liver infestation.
Yeah. So what is
some protozoan.
Is that the one?
Not hair dye.
The anchovy paste one?
Yeah, okay, yeah, Entamoeba, but crap, I need to go back and.
Okay, so it's not A. It's not appendicitis. No. Colonic infection with ascension via the portal tract could be. Gallbladder infection with ascension. She's got
That wouldn't cause bloody diarrhea.
Right.
PID probably wouldn't cause bloody diarrhea.
Yeah. So sepsis. All right. So I'm gonna go with B.
Yeah. Let's stick with B too.
Yeah, B is right.
Oh. Okay. What is the bug?
Okay. Crap. I think I thought it was a bug. I thought it was Entamoeba, and it wasn't. I'm going back right now. Gosh, I've studied so much.
Because Entamoeba would be bloody diarrhea with the liver abscess, right upper quadrant pain. Histology of colon biopsy shows flask-shaped ulcers. Which that doesn't really help us with the question, except just the bloody diarrhea. The biliary tract one, could that be what's that? Colon the one under after schistosomia.
Sclerosis.
Starts with a C.
Oh, okay, found it. Okay. So, yeah, it is. Okay, Entamoeba histolytica can seed the liver via the portal vein, thus infecting the colonic mucosa. So it's almost saying that, yeah, the Entamoeba histolytica starts in the liver and then infects the colonic mucosa via the portal vein.
Okay.
And let's see. So the patient does have a liver abscess due to Entamoeba. And it says amoeba can seed the liver via the portal vein after infecting the colonic mucosa. The patient's leukocytosis, positive stool, and travel history support a amoebic source of liver abscess. Amoebic abscesses are more common in men than women and are more common in the right lobe.
Okay, and this is certainly in the right lobe. Right on.
Mm-hmm.
And Yash, were you thinking primary sclerosing cholangitis?
Well, I mean, if you were just talking about bugs, but yeah, that would be one. But I was thinking of. Okay, let me look it up and I'll bring it up at the end.
All right. Anyone whose question this is?
Me, I think.
You're up.
Yeah. During an experiment, intravenous administration of high doses of drug X to an anesthetized animal produces an increase in its systolic blood pressure. The experiment continues a day later when drug Y is administered first. Then re-administration of drug X produces a decrease in the animal's systolic blood pressure relative to the experiment in the previous day. Which of the following pairs of drugs could produce this sequence of events?
Okay, so it has to affect the alpha receptor to increase systolic blood pressure.
Right.
So it's not acetylcholine.
So we're going to block alpha first, and then we're going to drop blood pressure. I want to say B, but hold on. But also, that would be the second drug.
What's D?
The experiment continue to Drug Y is administered. Oh, okay. So drug Y is first. So, right. Then drug X. Okay, so
yeah. So initially they did the experiment, and just to get an idea of what drug X is doing, it increases the systolic blood pressure.
All right, so actually, Yash, I think it is B, because phentolamine is a alpha blocker, and then if you give epinephrine after an alpha blocker, then you're going to have the beta.
It's not going to do anything.
Well, you'll have
But
the beta
epinephrine
effect.
will increase
It's like
beta,
the beta.
receptors, which will drop the blood pressure. So I would have said B. Ooh, drug Y being the second drug in this is a tricky one there. I'm going to go with B.
Yeah, I would agree.
Yeah, B is the right answer.
Oh, okay. B.
So wait, sorry, what did you say? Why does phentolamine produce a decrease?
Because phentolamine is an alpha receptor blocker, and epinephrine reacts to both alpha and beta receptors. But if you give an alpha blocker and then you give something that affects alpha and betas, then epinephrine's only going to affect the beta. Which is going to lead with a blood pressure decrease, a heart rate decrease, contraction decrease. So this is why when you have, because this is the classic question that they always ask on step 1 is, the difference between norepinephrine and epinephrine. Norepinephrine has very high alpha receptor attraction, and epinephrine has more beta receptor attraction. So if you were to give, in this scenario, phentolamine then epinephrine versus phentolamine norepinephrine, this one is going to drop the blood pressure, whereas norepinephrine, it's not going to make much of a difference. So alpha blocker and then alpha and beta receptor doer.
So I guess if in this case, if you gave the epinephrine first and then followed it up with phentolamine, it would be a different answer, completely different sequence of what happens with the systolic blood pressure.
Right.
Because so your map would decrease, right?
Right. So if you want to talk about like a clinical scenario where this is relevant, we're going to talk about, anybody know? Let's see. Clinical disease that you, the order of drugs you give matters?
Oh, you mean, yeah, I do. It's pheochromocytoma.
There you go. Yeah, pheochromocytoma. And it's the same thing. You have to give the alpha blocker first, and then you give the beta blocker. Because if you do it the other way around, you're going to send that person into a hypertensive crisis because their heart's going to go insane. But if you give an alpha blocker first, like phentolamine or phenoxybenzamine, it will block all the alphas to prevent them from vasoconstricting. Then you give them a beta blocker like, I don't know, propranolol or something, and it'll slow down their heart rate. Whereas if you just gave them the first one, if you gave them the second one off the bat without the alpha blocker, their heart's going to go crazy because they're going to have a reactive hypertension. So that's, yes. We all good on this one? Yep. We'll move on.
Alrighty. A 46. Yep.
Oh, go ahead.
A 46-year-old man comes to the urgent care clinic because of fever, severe headache, myalgia, and pleuritic chest pain. He has had these symptoms for several days. Physical exam shows fever and mild tachycardia. Long auscultation reveals mild crackles. Radiographic exam is consistent with segmental pulmonary infiltrates. Patient fails to respond to empiric antibacterial antibiotic therapy. And microscopic exam of lung tissue obtained from this patient shows spherules packed with endospores. This patient's history is most likely to reveal which of the following?
Coccidioides. Spherules. Arizona.
Correct.
We're going with A. Yeah? Is it Arizona? Oh.
Arizona is correct. So his symptoms obviously tell you that he has some sort of pneumonia type thing going on. And then, yes, the spirioles with endospores is characteristic of coccidioides, which is in Arizona, or southwestern U.S. area.
Yeah, so pigeon droppings, this would have been Cryptococcus.
Mm-hmm.
Caves is histoplasmosis.
Yes.
Tuberculosis is tuberculosis. Chemotherapy for leukemia.
Cavitary tuberculosis is actually going to be aspergillus
Oh, because you're going to
of the organism.
Yeah, a cavitary lesion. Gotcha. Chemotherapy for leukemia?
So that one, patients going through chemo for leukemia are going to be neutropenic. So they're going to be at high risk for opportunistic mycoses like Candida, aspergillus, mucor,
PCP.
all that stuff.
Okay.
And then patients with asthma are at risk for an allergic reaction to aspergillus again, and then that one's called allergic bronchopulmonary aspergillosis. So that's a special one there.
Gotcha. Uh-huh. Oh no.
A married couple, not couples, comes to the physician for routine prenatal counseling. The husband is 120 centimeters tall with disproportionately short upper and lower extremities, a large head, and a prominent forehead. He is unable to provide a biological family history as he was adopted. His spouse is of average height with normal constitutional features, and her family history is insignificant. They are concerned about their unborn child's height. Which of the following is the best response to their concerns?
For elephant?
Which, I'm sorry, I didn't hear what you said.
E for elephant.
E is correct.
So he has achondroplasia,
Yes.
and apparently it's like paternally inherited.
And it's autosomal dominant, so you can, assuming that he is heterozygous for that mutation, then either way, a 50-50 chance of the child being at risk for also having that condition.
Tulsi, with what you were saying, I think the relevance to the father is as the father increases in age, there is a greater risk of achondroplasia.
Okay.
So this is like the only one, because they say like, oh, the older a mother gets, then there's a great risk of mental retardation or any kind of risks with pregnancy as the mother gets older.
Mm-hmm.
This one is as the father gets older, there's an increased risk of achondroplasia.
Right.
Yes.
For it to occur sporadically. So the advanced paternal age is for a sporadic mutation, and then otherwise it can be inherited autosomal dominant, which we see here in this case.
Okay. Oh, and that would appear to be it.